Head trauma. Still, we're thinking about decap BTLS, deformities, visceration, contusions, abrasions, avulsions, penetrations, burns, tenderness, lacerations, swelling. So the head is part of the axial skeleton, and we really want to make sure that we understand that it's attached to the skeleton, the spinal cord, so we can have spinal cord injuries. And along with the head, it covers and encloses the cerebrum, the brain, and the spinal cord, or the brain stem. Now, the brain is important as far as cognitive function, and the brain stem is important in vegetative function. What we know is that the skull is an enclosed space with a finite amount of that space. Most of it pretty much occupied by brain matter. The other areas that are occupied within the skull cap is blood that perfuses the brain and cerebrospinal fluid, which cushions the brain and provides some kind of protection and some nutrients to the spinal cord. Now, if we add any extra pressure, swelling on the brain, bleeding internally into that confined space, we'll put more pressure on the brain. By putting more pressure on the brain, we basically suffocate it because it's not able to get enough blood, and the blood carries oxygen, and therefore it's not getting oxygen. As this space fills up with blood in there, the ability for the heart to push blood up in through the blood vessels to perfuse the brain is inadequate, impeded, or obstructed. This pressure inside the brain pushing against blood flow is called increased intracranial pressure, ICP. All right, so let's begin. Here they're showing you parts of the skull and how these bones fuse together. We also see the facial bones that make up the skull. We see within the skull is housed the cerebrum and the cerebellum, as well as the brain stem. And if we look at it really closely, we're looking at the skull enclosing the brain stem, and the brain stem protruding out through one pivotal hole at the base of this skull called the foramen magnum. If we put any pressure that causes this brain to swell and push and shift around within this enclosed space, it can push down on the brain stem, causing the brain to herniate, tentorial herniation. Now, head injuries can be very, very obvious because the head and the scalp, that tissue is highly vascular, it has a lot of blood vessels, and it tends to shed a lot of blood and bleed quite profusely. Here we have a laceration to the occiput and part of the posterior neck, as well as coming across to the right ear. This has opened up that area, and we consider this that it's an open laceration, but the skull or the vault has not been broken. So we have a closed head injury, but we have open tissue. Now, this is an open head injury where it's gone not only through the soft tissue of the scalp that covers the skull cap, but it has then broken through the skull plates, those bones that protect the brain, and we can see directly into it and see in brain matter. So the difference between a closed and open head injury. As the brain suffers injury, there may be bleeding that results. Now, this bleeding can occur under the dural or tough lining of the brain. Remember that the brain is covered by several layers. A tough layer, which is called the dura mater. This encloses the brain as well as is strongly adhered to the skull cap. just underneath that, that aligns and surrounds the brain tissue, then it's called the pia mater. And below that is the arachnoid space. And so we have these layers and potential spaces for blood to accumulate. This picture is showing you that the dura mater, the tough layer, has maintained its integrity, and there's bleeding below that layer. And it's pushing then on the brain. And we can see that that midline has shifted more towards the right. So this bleeding is called the hematoma. This subdural bleeding can occur suddenly. It can stay for a short while, which is weeks, and it can be chronic, which is to take months for this swelling to develop or bleeding to develop. Now, as we see the shifting of that brain, it's causing a lot of damage. Your patients may present as if they are suffering from a stroke. The only caveat is that they may have fallen and caused this to occur. Now, people that are more common to have a subdural hematoma are people that are a little older as their brain shrinks and atrophies over time, and those that are chronic alcoholics as they tend to stumble, and alcohol may have some issues with clotting. And so don't just think that they may be intoxicated. We do a good neurological exam to rule out that they don't have a subdural hematoma. The epidural hematoma, if we look in that right-sided picture, the tough lining that adheres itself to the skull cap has been torn away. This is as a result of that arterial bleeding, as it shows you in the left-hand side picture. This is under high pressure, and as that artery tends to bleed, it will continue to tear the dural lining off the skull cap, putting pressure against the brain. And as you can see, again, it's shifting that midline across to the side, causing herniation. Now, someone that has this sudden blunt force trauma that's so severe that causes this laceration to that artery. Now, during the time that they suffer this event, they may regain consciousness as the bleeding is tamponaded or obstructed or blocked, because it has a difficult time pulling the dura mater away from the skull cap. But as it continues to build up in pressure, as it's a high pressure system, arterial bleeding, it'll continue to wear and push away and separate the dura mater from the skull cap, adding more pressure into the brain. And in both pictures, our subdural hematoma and our epidural hematoma causes increased intracranial pressure. This means that blood flow from the heart that goes up to oxygenate and nutrients to be given to the brain is now being pushed back down against the heart's ability to push up, because the amount of space for the blood to occupy those blood vessels have become lessened due to this extra bleeding within the skull. Here is a picture diagram of what occurs at the time of injury. This victim or patient has been hit in the head, struck by a ball. He has an external injury or hematoma that starts to swell and bruise up. There may be a laceration or abrasion to the skin, and there may be some external bleeding. But what we look at is what occurred inside the skull cap and what's causing and what's occurring now to the brain, the organ itself. So now the organ starts to swell. There may be some bleeding that goes on. The person continues to move around, where now we have what looks like to have raccoon eyes that blacken the eye. They also may have battle signs behind the ear. They may have some autourea coming out from the ear, rhinorrhea from the nose if this was a skull fracture. But the brain is bruised up. And if that brain is bruised up quite severely, and it caused an arterial bleed, such as an epidural bleed, the patient will continue to bleed inside the skull, pushing more pressure onto the brain itself, causing the victim or patient to become disoriented, altered, unconscious. And at some point, that pressure is so high, the increase intracranial pressure is so high that it may cause them to have a seizure, convulsions, or start to posture. This may also render the patient with irregular breathing patterns. and an extremely high blood pressure, where the top number or systolic number is much higher and increasingly growing and getting higher and higher than the lower bottom number or diastolic. In the result of that, there's so much pressure that's being built up, the heart slows down, and that's what we call Cushing's triad. An increase in blood pressure and a widening pulse pressure. A slowing down of the heartbeat or bradycardia, and an irregular breathing pattern. Any one of those two could signify some type of Cushing's effect, or intracranial pressure that is now increasing. Some ideas that they may have suffered a head injury could be that there's a spider web of the windshield, and even more so if you see things like makeup or hair that's matted in there. But these are other examples of blunt force trauma. Somebody that falls, trips, gets kicked or hit can cause significant damage to the skull. External injury like hematomas, lacerations, but then bruising and bleeding internally inside the skull as a result of this. This may require the patient to be immobilized as the head sits on top of the spinal cord. And we should think that maybe people that have a head injury may also have a coexisting spinal cord injury because of the mechanism. Here you have two rescuers providing one, the manual immobilization of the spinal cord and the cervical vertebrae. The other person evaluating the respiratory rate and status. He may also have his hand along the carotid artery checking the pulse. That we can't see it. In this case, this damage is quite severe. We both have facial injuries as well as a head injury, which is somewhat obstructed by this photo. We can see that there is discoloration around the ears and behind the ears, as well as over both eyes. Imagine that we'd have to ventilate this patient with that type of injury around the oral orifice or mouth area. Air may seep out through the bag valve mass. And so in this case, an advanced provider might decide to go ahead and help ventilate this patient by using some other method. We usually use a Glasgow Coma Scale. This tells us how appropriate and how awake our patient is. Of course, we're going to ask those questions of orientation. What's your name? Where are you right now, and what is today's date? But we want to see if their eyes are open and spontaneously looking around. When we walk into the room, do they verbally respond to us quite easily? And when we ask them to do things, as far as moving their arms and legs and squeezing our fingers, can they do so quite simply by following our commands? As the mental capacity decreases because of either the increased intracranial pressure or some type of insult to the cerebrum or the brain, these indicators end up slowly going down. So an eye opening is usually spontaneous or to verbal, painful or no response at all. AVPU. Then we have our verbal response. Is it oriented, little disoriented? We hear words and then we hear incomprehensible sounds, just muttering of stuff, moaning, and then no response at all. Verbal commands, are they following it? Do they localize pain? When I go ahead and press on them, do they reach up and try to remove my hand? Or do they just withdraw and they just kind of push their arms away and shake a little when I press? Do they actually flex in some type of way where they extend or they come to the core? These are extension and flexion type of responses, which means that there's significant trauma. Significant trauma. Decorticate, where the arms reach up towards the head, internal towards the chest and body, and extension further away where they no longer can protect themselves and no response. Where you see the best response we can have is 15, and the lowest response we can have is 3, as in no response, no response, no response for eye opening, verbal, or motor. This is in a modified GCS score for pediatrics and infants, and you can tell it's, babbles and coos, irritable cries, those kind of things, and it's not necessarily obeys command, but just appropriate and spontaneous. And it seems to be very appropriate as far as their movement goes. Now, they're addressing the patient's airway, breathing, and circulation, And after doing so, they have identified that the person is adequately breathing, but is not ventilating where their saturation levels are high enough. So they went ahead and gave them oxygen by non-rebreather mask. They're still immobilizing the head, and they've just probably treated the primary assessment, airway, breathing, and circulation, treating the life threats. They're still immobilizing the head, and they've been moving on by delegating either the history to be taken, vital signs to be done, and then focusing in on their primary assessment of the kill zone or that head injury. They'd also be asking their team to bring on a spinal immobilization device and even a C-collar. Here we have a few different types of skull fractures. One's a type of depressed, the center one here where it's open and depressed. The other one, we still have an impaled object in them. So we have many different types of skull fractures. They continue on with their assessment after identifying what type of injury they might have found. They're doing a neurological exam. For us, we know that this would include getting orientation, and if they're unresponsive, then we go directly to pupillary response, eye movement, facial expression, tongue deviation, and speech, a facial droop. But in the simplest terms, pupils, hand grasp, pulse, motor, and sensory in the upper extremity, pedal, plantar reflexes, pulse, motor, and sensory in the lower extremities, to make sure that there isn't any type of central nervous system injury or spinal cord injury. Here they are showing you now more specifically basilar skull fracture type findings and significant head trauma where the eyes have turned black, the outside is ecchymotic and discolored. We have raccoon eyes, and probably towards the base of the skull we would have, or behind the ear, we would have battle signs. This diagram or picture is showing us that there is autourea fluid that is leaking out from the ear, and if it were absorbed with a 4x4 type of dressing, we would notice that there would be a halo where the cerebrospinal fluid would extend outwards, and the heavier red erythrocytes or red blood cells would kind of clog and clot inside, making this type of bullseye pattern. Now they're checking their painful response as they go down through their AVPU, and they're using a pain response by pinching the forearm. We've learned that we can do other things. We can use supraorbital pressure, trapezius muscle pressure. There still is use for sternal rub, but this one they're trying to determine if the right or left side, like a neurological exam, if there's a deficit. So we can also look at pinching along the nail beds, right, as we do our neurological exam. Don't forget to check for pulse and sensory function. Here they're showing us pupils, and on the right side we notice that the pupil is quite large as in comparison to the left side, and we have basically on this slide anisocorac pupils, which could have been documented by adding some drops, or the person, to dilate their pupil, or the patient has a prosthetic eye, or in some cases, some patients may have this as a normal finding. So find out what their baseline is. Here we have decorticate posturing. This would give us a level of 3 on our motor response based on a stimulus. They would end up bringing their arms and flexing them internally. Extension, this is where the arms extend away. This would give us a motor response of 2. These are significant findings for head injury. Here we have them now moving them and placing them onto a backboard. We need multiple providers here, multiple team members working as a team to log roll our patient, keeping that head in line with the spinal column, and then log rolling them back and placing them on the spine board. Now remember, spinal immobilization or spinal motion restriction, we may end up using some other method other than a backboard to immobilize them. Again, our summary is to go back over our National Registry Trauma Assessment Skill Sheet, identifying BSI, determining what we need to do as far as mechanism, personnel, equipment, and number of patients. Then getting our general impression, finding the level of consciousness, treating the life threats of airway, breathing, circulation, immobilizing the spinal cord, and manual stabilization of the C-spine. Then focusing our assessment on our trauma patient of injury, kill zone, and or delegating our sample history, our history of present injury and illness, as well as getting our blood pressure, pulse, and respirations. We work as a team to package the patient up if we are using spinal immobilization as far as our long backboard and getting our gurney, and then deciding that we need to make sure that our patient is transported within our 10-minute, our trauma 10 minutes. Please review your skill sheets, go over your notes, please read your text and lecture notes.